Hello, everyone. Welcome to the workshop Empowering Communities, Innovative Approaches to AI Health Research and Engagement. My name is Salvia Zeeshan, and I am the Regional Programs Manager at the Global Health Network. This workshop is brought to you by the International Development Research Center funded AI for Global Health project and the Mesh Knowledge Hub at the Global Health Network at the University of Oxford. It's a pleasure to have you all today. Today's session, which is day 2 of the workshop series, focuses on strategies for effective community engagement and building sustainable partnerships. A look at the agenda for the day. We will begin the conversation with Esther Lopez as she shares with us effective communication strategies and particularly how to tailor communication to diverse communities by using effective messaging and engagement skills. Afterward, we will explore case scenarios from artificial intelligence projects funded by the IDRC from the Global South. Speakers Zakaria Belrhiti, Victoria Mukami, and Enrique Cortes Rello will showcase their research projects explaining how they have developed a community engagement plan and how they plan to implement it to ensure better acceptance and sustainability in the future. Learning objectives for today's session. By the end of today's session, participants would have gained insights into practical communication and collaboration skills for successful community engagement. They would have heard about methods for building meaningful partnerships with community stakeholders. They would have learned about successful projects and best practices that demonstrate the intersection of community engagement and AI in health, and also developed an understanding of promoting ethical, inclusive, and community-centered practices in AI-driven health research. I'm delighted to witness such a diverse group of participants from around the world as being seen in the map displayed here today. The wide range of representation emphasizes the global significance of the topic. Thank you all for being here. We will begin today's program. Firstly, I would like to welcome Esther Lopez Alva. Esther Lopez is a communication expert specializing in community engagement and reputation management in the healthcare field. With a solid track record of leading multidisciplinary teams and collaborating with diverse industries, Esther has designed engagement strategies for leading clients in mining, retail, consumer goods, and more. Her experience includes reputation crisis management, development of strategic alliances, and executive training in strategic communication. Currently, she holds the position of Communication Officer at the Peru Center of the Global Health Network LAC project, focusing on health communication and community engagement. Esther's expertise lies in designing effective strategies to drive health projects forward through communication excellence. She holds a bachelor's degree in corporate communication and specializes in marketing, standing out for her strategic focus and ability to drive health projects through effective communication. Additionally, she is an MBA candidate, further enhancing her strategic acumen.
Good morning/afternoon to everyone, depending on where you are. Today, we are going to talk about effective communication strategies. Specifically, we are going to see how to tailor communication to diverse communities and use effective messaging and engagement tools. To begin, let me share some data from BMC Public Health. Engaging communities in health research through effective communication can lead to a 30% increase in participant retention and a 25% increase in the quality of data collected. So it's a really important topic. The objectives of the workshop is basically to improve communication skills to effectively engage diverse communities in health research. And we are going to see 3 stages in the presentation. The first one is about understand. It's really important to understand communication with our audiences, begin by understanding them. The second stage is about tools and strategies. We have to develop them to engage our communities with the objectives of our studies, programs, And finally, we are going to talk about effective communications skills for diverse audiences, not to only engage, but to retain our audience and build a relationship with them. So, we are going to see this slide about audience involvement process. This is not the focus of the presentation, but I'm going to explain it super fast to give you a better context. A constant element in the process is effective communication. It must be present from the first contact in awareness, and it's necessary to reach the end of the process, which is sustainability. This is like a customer journey map, where the customer is our target community, and we are going to see the touch points with that community. So this process starts with awareness, where the objective is to inform the community, basically to let them know what we want them to know as a first contact. Then, when we have captured their attention, we move to the next stage, interest. Here, the objective is to generate interest and curiosity in the community. Then, we are in the education stage. Here, we must provide detailed information and educational resources to our community. And overcoming this stage will allow us to reach the initial involvement, where we must encourage this initial participation in our program's activities. The next stage is the active engagement. Here is vital to convert that initial involvement into sustained commitment. But this is not the end of the process. The next two stages will allow us to reach the final objectives of a good relationship with our communities, audiences, or stakeholders. So in the letter F, we have empowerment. It's a stage in which we have to train community members to lead, if it applies, and or promote the program. And finally, the ideal is always to reach sustainability. In this stage, we can ensure that the engagement to the program is sustained in the long term. So let's start with the first stage about understanding your audience. And we are going to start with some definitions. Community is a group of people with shared interests and characteristics connected by social, cultural, or geographical factor. And it's really important to emphasize the or, because a community can be a group of people who share many characteristics in common or almost none, and be related only by one or two characteristics or interests, and related by geographical location, interest in a program, some disease. And we have here diversity. Is the presence of a variety of backgrounds, perspectives, and characteristics within a group. So let's see an example situation. Imagine we are conducting a study on diabetes, and we have a diverse urban community. Within this community, we have groups with different ages, interests, cultural backgrounds, socioeconomic levels. Each of these groups may have different knowledge and beliefs about treatment and access to health resources. So we have this example of a diverse community. What do we have to find? We have to link these groups and these different persons, looking objectively and holistically. We have to identify common needs. This will allow us to find these needs, concerns, and shared values that can be the starting point for designing inclusive messages. So let's keep talking about this urban community. Despite the difference, many community members share common concerns such as access to affordable quality healthcare. It's a really important interest they share. So by focusing on this common need, we can create messages that are powerful and encourage participation in our research, in our program. But that's not all. we are going to see now segmentation strategies. And it's really important to learn we have to differentiate, but not to divide our community. We have to personalize messages without fragmenting or isolating community members. For example, to address diversity, we segment our communication for young people and to older adults. And we use different channels. For young people, we use social media. And for older adults, we can organize talks in community center or some health centers. And we focus the message for young people in prevention of the disease. And for older adults, we can focus our message in diabetes management and treatment. So we are segmenting, but we are not dividing. Now we are going to talk about engagement tools and strategies. And the first tool are key messages. They are really important for any communication strategies. These key messages have to connect, have to be clear and simple, and must have powerful storytelling. Our key messages are based on common values. And if they are based in these shared values, these common needs, they will reach different segments of the community. Also, they have to be clear and simple. We have to use this type of language to be easily understood by the entire audiences. And we have always to remember, messages must be built according to the audience, but also our key messages has to be built according to our objectives. What do we want to communicate? Finally, we have to develop a narrative that humanizes the messages as well as inspires and motivates the audience to take action. We have to end our messages always with a call to action. And we have to support messages with valuable data. This data has to be valuable for our audience. Maybe we have some technical data that is really important to us, but we have to empathize with them and share valuable data for them. We are going to see this part in a minute. Right now, we are going to talk about communication channels. It's really important to select the most effective communication channels for each target group, but also for each program. So it's really important to generate a space for discussion on the advantages and challenges of different platforms. Here are 5 examples analyzed in a very, very general way. For example, email is personalized, is easy to follow up, but it can be ignored. We have social media with high interaction, wide reach, but requires constant content. Do we have the time for this constant content? Traditional media, we have broad reach and credibility, but it's really expensive and less targeted. So we have to analyze if we have the resources. We have also instant messaging. It's a really quick communication with a high open rate, but it can be intrusive, sometimes really intrusive. So it depends on your community or the segment you chose. They could be really technological people or people who do not read much email. So you have to analyze it after understanding and segmenting your audience. Finally, we have webinars, conferences. They are really interactive, really educational, but it requires planning and time. So again, it's really important to generate this space to discuss channels according to your resources, your timings, and your type of community. And we have feedback and improvement. First, we have to listen to the community feedback. You can find this feedback through the channel you have chosen to communicate with your community. And after analyzing this data, it's really important to adapt communication. How much? Okay, we have to adapt communication until the target communication metrics are achieved. Until we've achieved our objectives, we have to adapt our communication based on the feedback data. And now we are going to talk about communication skills for diverse audiences. We have many communication skills, but we are going to talk the two most important for diverse audiences. The first one is empathy. The ability to understand and share the emotions, thoughts, and perspectives of others. How to communicate with empathy. And why is it important? Okay, how? By actively listening, showing genuine concern, and acknowledging the emotions and perspectives of others. Is that important? Okay, let's see. Studies show that empathetic communication can improve patient satisfaction by up to 60%, BMC Public Health. And the second one is about cultural sensitivity. It's being aware of respecting and valuing the cultural differences and diversity of individuals and communities. Research indicates that culturally sensitive care can reduce health disparities by up to 30%. This information is from the US Centers for Disease Control and Prevention. So we are going to see another example situation. It's a really basic example situation, but it's going to help me show how is it important. So we were talking about this diabetes study with this diverse community. Imagine we are discussing health eating options. What do we have to do? We have to acknowledge and validate and empathize with different cultural backgrounds and different cultural diets. How? Suggesting healthy adjustment within existing dietary frameworks. Why? Because this single ideal plan, it's not going to be practical for everyone in our community. And the ideal, only unique plan doesn't exist anymore. People is different. We have different cultural backgrounds in a diverse community. So we have to suggest these adjustments to reach them all. And now I'm going to share with you a slide that I hope will serve as a guide or example to develop your own communication materials. There are many formats to disseminate our messages through the most effective channels according to our target. And I'm going to show you 3 formats. The first one is an infographic. This infographic we can place, for example, on a poster in a medical or community center. We can also paint it on a mural. This format allows us to provide a lot of data in a friendly and visual way. And how are we going to disseminate this information? It depends on our audience. So we have to understand and segmentate. We have also a mock-up of a video that appeals more to identification and interest. We use utilitarian content such as food tips, recipes. We use it as a bait. And when we have captured the attention of our audience, we provide a short but powerful message with the only necessary data. For example, here we have the diabetes clinical trial advances because of your participation. You join the more than 100 participants who are already helping to change lives. So we see this woman teaching us a recipe, and she speak with this powerful message, and then we end with together, stronger, join us. We end with a motivating call to action. And finally, we have another format, a web or an app. We have a much broader and complex format that will allow us to disseminate information, but always based on our audience. We can disseminate many elements and materials, but always remembering that they must be based in our key messages and objectives. Also, connect, be clear, and have good storytelling where we can share articles, infographic, videos, and more. But the resources required by this format, web or app, are greater, which is why it's important to have discussed the channels we are going to use for our communication strategy. And finally, we have never to forget communication goes beyond words. So please, let's create emotional connections and highlight the relevance of health research of any program to the real lives of the different communities involved in our projects. Studies show that healthcare providers who effectively communicate and connect emotionally with patients can increase patient adherence to the treatment by up to 19%. Journal of General Internal Medicine. So there are many emotions. Use them to create emotional connections because communication goes beyond words. I encourage you to harness the power of communication, and thank you all for your attention.
Thank you so much, Esther. We have time for some Q&A, and I have pulled some questions that were in the Q&A section that were posted. So I'm going to take some time to present those questions to you, Esther, and for you to answer them live. A participant in the workshop has a question about how do you address and incorporate the needs of people with disabilities in your communication plans?
We have to avoid having communication blind scenes. We have to analyze our audiences. That's why it's really important to understand our audience and segmentate them to know each different group which is part of our audience. People with disabilities, people with different cultural backgrounds, people with different socioeconomic levels. So we have to analyze them, we have to understand them, and we have to find these common shared values to reach them all, to include them all in our message, in our communication strategy. And we have also to be able to use different channels, to use different kind of messages to talk to everybody in our community.
Thank you, Esther. There's another question, similar, but for a different category of population. So most of it would apply, but if you would also like to add anything specific, this is pertaining to pregnant teenage girls and specifically related to safe motherhood. And Simon Kivuti wants to know how you would recommend people to segment messages for this particular population.
Okay, we are going to remember communication goes beyond words for this specific target because it could be a sensitive target. So we have to empathize and have sensitivity to talk to this specific target. We also have to empower our community. Do you remember when we saw this process? Okay, so we have to empower our community, and our community is all our community, or all those segments in our community. And if we have to reach this target, we have to think in them, we have to understand them, and we have to empathize with them. And empathize is not to look at them from my position, is to left my position and to think as they would think and try to feel as they would feel. Right in that right moment, we are going to be able to build a powerful message for our audience. When we really understand them, not since our position, not from our position, but from their position, their cultural background, their emotion, or the moment they are going through.
Thank you. And there is this question about the overall group. So outside of looking at the subcategories, we have a participant ask question about what the components are of a compelling message that resonates across the different demographic groups. If there is a thing like that, Esther.
Can you repeat, please?
They want to know what the components of a compelling message are for all of the different demographic groups. What would be the essence of a message or the different components that would target everyone and across all populations?
Okay, a message across all our community. First, our key messages has to be aligned to our objectives. It's really important when we build this message has to be aligned to what do we want to achieve with our communication strategy. And to have a really good message, we have to see these 3 characteristics we thought in the presentation, which are key messages, clear language, and powerful storytelling. These elements are going to help us to connect with people, to be understood by people, and to engage people by a powerful storytelling. So we have to think in these 3 elements as a must when we develop any message, and we can change the storytelling, for example, depending on the format, the channel, and the type of our community. But we always have to use these 3 elements.
Amazing. The next few questions are about communication channels. I'll try to club it for you, Esther. So Mulat Bai wants to know what communication channels can be used in low-income countries and how they can be best used. And similar question is from Helena Boene, who wants to know how we can use certain communication channels in a rural setup, especially where people are unable to read and write. So what communication channels and how you would recommend they be used best in these 2 settings, low-income countries and rural settings?
Rural settings, okay. So let's go out to understanding our community. Every community is different. So we have to first discuss these channels. We have many channels available. We have to discuss it and to align them to the resources we have in our program. Because maybe we don't have the resources or the tools in the moment, but now we have new tools and platforms who can help us to reach different people. For example, if I have a community and they are not able to read, I can go with the format of a video. And in the slide I show you, in the mockup, we have some text, but we do not use the text because we know our audience can't read. So we use powerful stories, powerful testimonies, and we can use, for example, some podcast, or we can use quick messaging for share videos, or audios or podcasts through, for example, WhatsApp. Also for low-income countries, how is best to use communication channels? We have to, again, have this discussion, and we have to understand our community and cross it with our resources in both cases. So we understand what our community needs, what are the messages I have to, or I want to communicate with them, and also cross this with, link this with what resources do I have? What do they use more? For example, in Latin America, people use social media more than professional social networks. So if you want to achieve a specific community who use more WhatsApp and TikTok than LinkedIn, you have to look for tools to communicate with them through these two platforms. And we can use many tools to help us to build our formats, to build our infographics, our videos. We can use IA. So we have to have this space of discussion, this space of understanding, and this space of linking information with the resources we have.
Wonderful. We have time for one more question, so I'll present it to you now, and then I would request you, Esther, to look at the Q&A and answer some of the questions there, because there are quite a few that we will not be able to cover before the next presentation starts. So just one more question. Kat Vasquez wants to know how you would approach pre-testing communication materials to ensure that the messages are consistent across different target audiences and using different languages. Mainly about any approach towards testing the communication materials, especially if they are in different languages and for different target audiences. Any approaches for testing that you would adopt and recommend?
Okay. How would we approach testing communication material? We have many tools. We have, for example, in web for ads, the test AB. If we are going to use a digital format, we can test, for example, two pieces. Let's talk about infographics. We can test two infographics, same content, different icons, different colors, one in landscape, the other one in portrait, and we can run a test, an A/B test in the platform, Facebook, Google. And after we get feedback data, we are going to, when we get feedback data, we are going to know which one is working better than the other one. Also, we can test it in the old way. For example, if we don't have the resources to use ads or use a Facebook or Google or TikTok ads platform, and we are going to go with organic communication, I mean free, we can test our materials by running them. It's a really important way. We have to try, receive feedback, and adapt. It's a rule. So if we want to test a video, we have to expose the video to our audience, and we have to listen. It's really important to listen. It's the better way we are going to know if it's working or not, if it's liking or not, and if we are achieving some objective or not, and we are going to receive valuable data and feedback. Feedback from our audience is going to help us to adapt and adapt and readapt until we achieve our objectives. But we have to prove it running communication. This is the secret.
Amazing. Thank you so much, Esther. Those were very effective communication strategies as well as specific tools that you shared with us today. We will now move to hearing on case studies from the different regions. We have our second panelist here today, Dr. Zakaria Belrhiti. Dr. Zakaria has a PhD in Public Health and Medical Sciences from Rello University, Brussels, and the Institute of Tropical Medicine in Antwerp, Belgium. His PhD thesis focused on complexity, leadership in health. He's a principal investigator of the sub-grant of MENA funded by IDRC, which aims to save mothers' lives using responsible artificial intelligence in Al Haus region, Marrakech, Morocco. The goal is to improve equitable access to reproductive health for Moroccan rural and deprived populations. He also holds a doctorate in medicine from the Faculty of Medicine and Pharmacy in Rabat, a master's in public health, and a master's in public management. He has solid managerial experience as a former chief executive of Mara Provincial Hospital and has been involved in a multitude of international grants, including EU-funded projects, RIP-SEC, Evidence Synthesis Project in DRC, evaluation of knowledge translation platforms in the Embu region, and MENA projects, as well as migrant IDRC interventions to improve access to sexual reproductive health for migrants.
Thank you. Thank you very much, Sylvia, for the brilliant introduction. I'm very pleased to be among you, among this network, and I'm very glad that the Global Health Network for the invitation to be among this huge and brilliant community. Let me introduce the topic. First of all, this project is part of the MENA network funded by the IDRC and the University of Mohammed VI, University of Science and Health, will be the implementer university. First of all, this project is about saving mothers' lives. It's about reducing maternal mortality ratio through using artificial intelligence clinical decision support systems in rural areas in Marrakech. And I'll be presenting the rationale behind using behind this project before. Just an overview of this project. First of all, in Morocco, we have made significant progress in terms of reduction of maternal mortality ratio. From 2008, we were at 227 deaths per 100,000 live births, and we moved recently to since 2018 to 72%. So this is like 3/4 reduction of maternal mortality ratio. However, we still have some persistent challenges. Where these challenges are mostly in rural, remote areas where there is an equity challenge. First of all, there are many aspects of this that causes this inequitable distribution of healthcare access. First of all is the first and the third delays that are related as well to lack of quality antenatal care, depending on, normally in rural areas, we have young professionals, so they lack the sufficient skills to identify the high-risk pregnancy and transfer them and refer them to the tertiary hospitals quickly and early. This was backed up by international evidence as well as local and contextual evidence in Morocco. And so to this end, we developed and crafted and designed this project in order to contribute to the reduction of maternal mortality ratio by improving the accurate clinical diagnosis. So this will help out in reducing the delays and then therefore reducing the maternal mortality ratio. So we framed our specific objective as follows. First of all, the idea is to develop an AI solution based on neural networks to help professional and young professional to accurately diagnose and a high-risk pregnancy and transfer them to the different point of care at tertiary level as well as secondary level, and then empirically test this this solution in one point of care facility, and then try to implement it in Al-Hawz province in 12 health centers, so primary health care centers, 5 in rural areas and 5 in urban areas. Following these three main objectives, we will carry on an evaluation of the implementation process, as well as to bring some lesson learned to the scale up for the Ministry of Health and Social Protection. So why we selected Al-Hawz province? I don't know if you are aware of this. This province has been the target of a huge earthquake recently in 2022. And the idea is that this rural citizens living in this remote area was devastated by this earthquake. And this also is another element that increased the inequity and access to healthcare. So this is why we brought this theory of change, which explain why we have crafted and designed the project. So as I presented earlier, the first and third delays as are the key causal roots that explain this high maternal mortality rate in rural areas. So in order to address the needs of this vulnerable population, we need to provide a healthcare professional with adequate tools in order to carry out a timely diagnosis, detection, and referral on time of high-risk pregnancies. And then, so the three elements that will help us doing it is EI predictive model, capacity building of health workers, and funding that had been provided through the MENA project and EDRC. So we divided our project in 5 work packages. The first one is, first of all, we are doing actually finalizing the evidence synthesis on the different application that uses artificial intelligence and neural networks, application in maternal and neonatal health team in more specifically, but and then the development of the open access, the implementation, the evaluation. This will address 3 main levers. The first lever is the clinical domain, which is the clinical diagnosis. The second level of or mechanism of change would be the healthcare delivery. We will introduce a solution that could help the organization of healthcare and then timely diagnosis and timely referrals. And the third element that is key to the change and the sustainability of the project is the political leadership, the engagement of senior healthcare stakeholders, as well as local and regional stakeholders, in order to make change in the behavior of health workers, their ability to diagnose precoce in a timely manner, the high-risk pregnancies, in order to improve the outcomes for this vulnerable population. So this is why we presented our outcome. I'm not going to specifically detail each outcome, but the idea is that the scoping review will bring some lessons learned from international evidence. The second element is the tool development of the neural network artificial intelligence solution that is based on algorithms that allow the prediction of the high-risk pregnancies, as well as the accuracy of the model. So this is the tool development using accurate data gathered from data collection in primary healthcare facilities, and then the implementation of the solution in the 12 rural, 5 rural and 5 urban healthcare centers. So then we will bring evidence on the specificity, the accuracy and sensitivity of the model. But in addition to this 3 work packages, there is another element that needs also a stakeholder engagement component, which is the evaluation of the program that needs also to be participatory. So this is what we call the realist evaluation, to understand how this intervention will work, for which type of population, for which actor, and in which condition, and to draw some lesson learned for the scale up, and then contribute to the evidence how AI clinical decision support system might work in low-income setting. So this is actually the actual topic of this sharing, is how we have drafted or crafted the community engagement strategy. So from now on, I will be naming it as stakeholder engagement. So first of all, we mapped the different stakeholders. First, there are providers, our key actors, our key beneficiaries of this solution will be the providers in order to serve the patients. So the providers, we need to engage them, to train them, and to convince them and to persuade them into the utilization, as well as to map the different healthcare providers that will need to be engaged during the implementation process. For the patients, we need to tailor as to make contextual sensitivity of the solution to their needs. But also in our setting in the MENA region, Middle East, as well as North Africa, we need always to have a political engagement at strategic national level at the Ministry of Health, Social Protection. So this is why we engaged with National School of Public Health as well to build partnerships around this project in order to implement the solution. And then another way to build an engagement strategy is to create an advisory board that will be composed, or that will be comprising stakeholders from the Ministry of Health, from the Ministry of Foreign Affairs, from departments that deals with health of population, namely the Direction of Population, and the university staff, the university president, as well as the researcher and the community. And then the broader stakeholder, which is the research community at the MENA region, where that would be involved in the evaluation of the project and the sharing of the lesson learned. So this kind of engagement strategy is built on what Abdul Ghaffar mentioned as the embedded research that is embedded in the context, in the embedded in the health policy. Embedded research needs that policymakers are engaged in the initial phases of the project in order to secure the sustainability and the buy-in from the different actors. So just to present to you the different work packages, work package 1, the second, the details about the development of the AI solution, testing the relevance, the evaluation, and the dissemination of different findings. So we need to also to design engagement strategies that are adapted to each phase of the project. So first of all, we already have done some stakeholder engagement strategy with national stakeholders, namely the Ministry of Health and Social Protection and the Ministry of Foreign Affairs, as well as presenting the project to the ERB. And then the second phase of stakeholder engagement is during the implementation of the project, while organizing what we call a stakeholder engagement workshop, where all stakeholders are gathered in a space that allow the sharing of their interests, beliefs, as well as to adapt the solution to their needs. And then after the implementation, we also include another way of engaging stakeholder during the evaluation process and evaluation design. In order to be successful in this stakeholder engagement, as we plan to do actually, this is an example of the first phase of the project implementation. So we wrote a policy brief. Policy brief about our own project that we submitted to the Ministry of Health and Social Protection, as well as the Ministry of Foreign Affairs. And this has allowed us to have an institutional framework and institutional authorization of the whole thing. So we have informed and consulted with high senior strategic level to allow that the success of the project. So this has been followed by an authorization of the Ministry of Foreign Affairs to our project that allows us an approval. And then we also built on a guide that is called the MAPS toolkit, developed by the Global Health Network as well as the World Health Organization, where the partnership elements in the planning of any project is key in terms of maintaining the sustainability, the buy-in of stakeholders, and the success of a project that is based on mobile health technologies and AI solution. So we need to integrate and incorporate stakeholder engagement strategies during different phases of the project. That includes not only the partnership, but also other aspects and elements, as the previous lecturer said, normally the technology, the resources that we have, and the monitoring and evaluation. Another aspect of the stakeholder engagement or the participatory aspect is also embedded in the evaluation phase of the whole research project. And to this end, we need to present another way of doing evaluation is what we call the practical participatory evaluation, where we involve stakeholder in the design of the evaluation process, in the data collection, and in the dissemination of the results of the project. First of all, we will carry on a stakeholder engagement workshop, another involvement during the individual interviews and focus group discussion, and another involvement phase at the end of the dissemination of results. That would be the workshop stakeholder engagement to adapt and formulate recommendations that are tailored to the need of the different stakeholders. So we need also, during the development of stakeholder engagement strategy, to take into consideration the potential risk that are out there that need to be alleviated by mitigation strategies. First of all, we need to adapt our project to the priorities of the key stakeholders at national level, at regional level, but also at local level. So sometimes we might have conflicting priorities. So we have made sure during this project to align our AI solution to actual strategy of the reform of the healthcare system that is based on 4 components. One of the components is the digitalization of health intervention. So this is why the AI solution would be another element that is totally aligned with stakeholders at national level and local level and their interest. The second level is we need to mitigate a lack of interest in local health authorities and now the communication strategy, but also we need to build on the connection between the National Population Health Directorate at the Ministry of Health with connection with regional health officers and at a local level, local health managers, as well as healthcare providers at local level. And each region, the direction of health directories has focal points. So we integrated the National Population Health Directories within the advisory boards. This is one way also to engage stakeholders. The third risk that could also could be brought during the implementation of the project is the lack of commitments of health workers. So another element that we integrated in our project is the capacity building of health workers in using the AI solution. So in order to do that, we have an ecosystem at Mohammed VI University of Health and Sciences that will allow them to have training in our facilities, and this will help them increase their motivation and reduce the psychological barrier in using AI solution, and continuing monitoring and seeking feedback from healthcare providers. If our solution is user-friendly or not, will help improve their trust and their commitment. The fifth element is the contextual constraints. We need to be aware that there is no solution that fits all. There's always contextual condition, and we need always to adapt. So poor quality of data, this will be managed through accurate connection and partnership with the direction of planification and financial resources, as well as the working with their strong health information system in making data accurate in order to align with our health priorities. So this is just to share our timeline, as I've been asked by the organizer, a scoping review, and I invite anyone that is interested in collaborating in the scoping review, the data extraction, as well as the publication process. I invite everyone to do it. And then the development of the timeline, the development of the solution, as well as drawing lesson, we'll be sharing this. The next step are normally we are waiting for the ethical review board for their approval, the data collection, tool development, tool implementation, and the participatory reality evaluation will be done in year 1, year 1+1. So just to, I'm not the only one in this project, so I need to acknowledge the contribution of researchers and team members, Sarah Van Bell and Sana Contractor from the Institute of Tropical Medicine, Bushra Asrag, an expert in sexual reproductive health in the National School of Public Health, Imad Badisi at the Mohammed Center for Research Innovation, and this. And then just to give you an example of an event of stakeholder engagement workshop, I invite you to see the video of a stakeholder engagement project that Louis kindly will share with you, just to have a hint how a stakeholder engagement workshop as another tool or another way to engage with stakeholders.
Nous avons organisé aujourd'hui un événement assez important qui parle de l'incorporation des données probantes dans les décisions. Ces décisions portent à l'échelle des politiques de santé, mais aussi à l'échelle organisationnelle, mais aussi à l'échelle clinique. Et on a, avec le partenariat de l'IS Global Barcelone et avec le soutien de l'Organisation mondiale de la santé qui soutient les questions des initiatives de traduction des connaissances et de centres de connaissances à l'Université Mohammed VI des sciences de la santé, en coopération avec l'École internationale de santé publique, le Centre Mohammed VI de la recherche et innovation. Nous avons organisé une rencontre qui a réuni des décideurs, des cliniciens, des responsables du ministère de la Santé et Protection sociale, des experts internationaux en synthèse d'évidence, en traduction de la connaissance. Et l'objectif de cette journée, c'est d'émettre des recommandations sur comment construire un réseau de centres de gestion de connaissances pour collaborer ensemble, pour mieux transformer l'évidence et les données probantes en actions concrètes sur le terrain qui va améliorer la santé de la population, qui va améliorer l'organisation des structures de santé et qui va améliorer aussi les décisions en santé publique.
Fantastic seminar, a fantastic how to make science have an optimum impact on policies and practices, how to change the society. And I think that today we've had the chance to listen to a lot of examples.
So today's session was actually fascinating because knowledge translation has a big cultural component. So it's always very enriching to see how other people in other countries, other cultures do this knowledge translation and what works for them, the techniques they have developed. And so I think there's a lot of potential here for all of us to learn from each other.
Voici grosso modo l'essentiel des discussions que nous avons eues aujourd'hui. C'était un débat extraordinaire avec beaucoup de partenariats inter-institutionnels et nous comptons construire sur cet événement pour plus de collaboration inter-institutionnelle.
Thank you very much for listening, and I'm happy to answer some of your questions. Thank you.
Thank you, Dr. Zakaria. That was indeed very informative. I'll relay a few questions that were posted in the Q&A, and then I would request you to answer the rest of the questions in the Q&A. tool itself, especially also because there are some project-specific questions that people have posted there. But I'll ask you a few questions live here today. One of them is on the challenges that you encountered, particularly in the first stage of stakeholder engagement and how you address them.
Okay, so should I explain more about these challenges? Yeah, we are still in the early phases of the project, and there are always challenges in terms of convincing and key stakeholders of the relevance of the project, but also in seeking ownership, because it's not our project, is common into common projects that needs to be owned by all institutions involved. So the first challenge was about how to engage them in giving us an approval at the Ministry of Health, which is at strategic level, but also with institutional level, institutions that are key in terms of implementation of such project. So these, we are still in early phases, but we may also encounter other challenges as well.
And there were a few queries about the MAPS toolkit and if it is something that can be used in every setting, also if it is available.
Yeah, I'm going to share that on the chat later on. Yeah, it's available. It is adapted to digital technology solution, and where there is a comprehensive elements that need to be thought. It is a comprehensive model that allows us to keep in mind the different elements that we may encounter: financial elements, sustainability elements, partnership elements, governance, technology. But it is not the second part of the question is it adapted? It is not. There's no one best framework that fits all setting. There's no such thing as one best way, but it is a framework that helps you reflect on your own context, on your own experience, and you may be able to adapt it to your own setting. So this is why it is interesting to have a toolkit, a comprehensive toolkit with different component that allows us to self-reflect on that. But we need also a contextualization effort with our country data setting.
Thank you so much. So again, requesting you, Dr. Zakaria, to take a look at the Q&A and answer some of the questions there. There are some very interesting questions and also some project-specific questions there. Thank you. We will now move to our second case study, and this is from Africa. I'll introduce the third panelist, Victoria Mukami. Victoria is an IT professional specializing in maternal health with a doctorate in information technology. Transitioning to health informatics, her research now centers on cancer, notably breast cancer, with a particular focus on improving women's health outcomes. She leads innovative projects such as HIV chatbot to empower and support youth and adolescents in health-related decisions. In addition, she is working on reducing the delays experienced by women between pre-diagnosis and diagnosis of breast cancer. As a lecturer in IT, Victoria fosters critical thinking, teamwork, and design thinking in student multidisciplinary projects, ensuring a holistic approach to problem solving. Her certifications in health complement her expertise, and her interest in artificial intelligence underscores her commitment to women's healthcare. In addition to her diverse academic background, Victoria has extensive experience in information technology and health research. Her goal is to leverage technology to transform the health for women. Over to you, Victoria.
Thank you so much, Salvia. I hope you can hear me okay. Thank you for the introduction. It was said, my name is Victoria. I'm part of this group that you can see in front of you. So we are working on a project, and our project has a small acronym. It's called BESHTE, and it's a chatbot. And so BESHTE generally means friend in Swahili, or in slang, Swahili slang. And our chatbot basically was targeted towards youth, and we were trying to do a couple of things, like you can see, to enhance HIV testing, status awareness among the youth, and status disclosure among adolescents, boys and girls, and also university students, so young men and women in Kenya. So just to start us off, what we expect, we'll do a bit of an introduction to this particular problem, why we were trying to solve it. We'll also take a look at the objectives, what the project entailed, some of the activities. The activities is where I'll be speaking about the stakeholder engagement and why it was necessary to have stakeholder engagement. And then we'll have a timeline and some questions. So just to brief you, our project has been funded by HASH, through HASH and IDRC. But just to give you a bit about the HASH network, so it's the Hub for Artificial Intelligence in Maternal, Sexual and Reproductive Health. In my case, I'm in the adolescent track. The team is doing work on the adolescent and youth track. And basically the network normally tries to foster community collaboration and learning. And we have got different clubs within the HASH network. If you check out on the website, you'll be able to see one of the key ones is community engagement. It's one of the clubs, and we do offer webinars. So this is just a brief of as per the map is where the projects have been awarded. Like you can see, there's a lot of East Africa ones. There's Angola, and then, sorry, not Angola, Namibia, and then we have a bit of West Africa. So our problem, we came to see that, especially with youth, university students and adolescents, there's a big problem when it comes to the kind of knowledge they have around HIV and AIDS. We also discovered this is somewhat the forgotten generation, especially within, I want to say Africa or Kenya, mainly because they're in that stage of their life where a lot of their information comes from each other, which may not be correct. Additionally, this age range, 15 to 24, is or are the, I want to say, the youth who parents might have contracted HIV, and so they were either born with HIV or lost parents to AIDS. And you find that either they've been taking antiretroviral drugs for almost all their life, and they're getting to a point where they're getting tired. And so we realized traditional interventions basically have a low uptake, where you've got brochures or even announcements on TV. They don't watch TV to begin with. And we saw that we require some innovative techniques. And one of those was we discovered that most of them have got phones, and they are very technologically perceptive. So depending on which age range you are in, if you're like me, they probably know the phone better than I do. But then this is also the discovery age where they are prone to risky behavior. They are experimenting. We might not want to see it, but they are actually experimenting. They're learning to see where their bounds are. And they end up, especially the university one, they end up not really caring about HIV, but are more concerned about other issues. And so the objectives of the project were, number one, to undertake a situational analysis before we could develop a knowledge base. This knowledge base was to be used to develop the chatbot. The second thing was to develop and train the chatbot based on the knowledge base we created. And then the third objective, which is what we are currently working on, was deployment and validation of the chatbot to selected participants. And I'll go through that shortly. So just about the project, we were targeting adolescents, 14 to 19, who are in high school. We were working with local high school, and we were not working with the capital city. We were dealing with a rural population. So 2 counties where my university is located, University of Embu, so Embu County and Moranga County high schools, and the universities within those counties. So each of those counties have got one university, and this is youth between 19 to 24. So just about the cohort, like I said, we dealt with high schools, 2 counties in Kenya. We had 4 high schools and 2 universities, and a lot of the data collection was done with the end user in mind. So a lot of stakeholder engagement, a lot of user engagement that I'll be discussing. So I'm going to be reviewing the objective, each objective one by one, just for us to understand the activities and to show exactly how we're able to bring in engagement. So engagement was one of the bigger focuses because we've realized a lot of projects tend to come up with a solution and think this is a solution that will work for the community that they are investigating on. Normally, once the project is done, it fails. But then we realized if we involve the stakeholders and the users earlier on, then we have an advantage. So our first objective, which was conducting a situational analysis, basically involved engaging the stakeholders through a stakeholder forum. We had some consultative forums, and this was done with the users. These are the high school students and the university students. And this is what led to the development of the knowledge base. So some of our stakeholders that we had included guidance and counseling teachers from the high schools. We had nurses who work within the government hospitals, specifically within the HIV section or within the youth-friendly section. We also had community workers, community health promoters, as they are known here. We had the government, or we want to say the county, what do you call it? The county head of health, especially HIV. We had private counselors who came in. So those were the stakeholders. Now they came in, gave us their perspective, and even gave us questions around some of the things that the youth ask them. And you can be able to see some of the stakeholders happening here. And for the forums, for the focus group discussions, like you can see here, these are all focus group discussions where we had meetings with university students, and these university students were actually going ahead and working to give us frequently asked questions so that they can be able to. So we had students coming in and asking, giving us questions. We had discussions around what are some of the risky behaviors. We had questions around some of the things that need to be done. And this is what formed the basis of our knowledge base. Moving on to the Okay, there we go. So these are just some of the ones that we did with the high school students. These are just focus group discussions that we had trying to discuss the different materials that we required for our knowledge base. And we had some very interesting questions that we hadn't even thought about. Of course, this was beefed up with number one, questions and answers from the government. The questions that they've been getting, frequently asked questions, some statistical questions. And then we moved on to the second objective. So we developed our knowledge base. This knowledge base essentially was made up of about 3,000 to 4,000 questions. And these questions were vetted by nurses. These questions were also vetted by the counselor. They were the students, the teachers within the high schools also just reviewed some of these questions. And with this data, sorry about that, we pre-processed it, and then we went ahead and developed our chatbot. We trained the chatbot, and this particular chatbot, like I said, is called Beshte. Now, we had a stakeholder review for the chatbot, just for them to see how it works, to see whether the questions asked, whether they make sense or not. So this is just the outline of the knowledge base development. You can see at the initial, we sourced questions online through the various government websites. We even went as far as CDC to get questions from them, to get questions from various international NGOs. And then we also picked student FAQs from the focus group discussions. We picked expert questions from their stakeholders. And then for the first draft, we had nurses putting answers to these questions, and these are graduate nurses, putting answers to these questions, trying to review and rechange how the questions were asked, putting in various variations and answers. Now, what I did not mention about our chatbot is it's multilingual, both in English and Swahili, and it can do a mix of the two to cover for slang. And so we had Swahili students translating whatever questions the nurses were able to come up with. And then we finally had the questions and answers reviewed by an expert to make sure that they were correct. And this is just a session where they were reviewing the questions, they were reviewing a bit of the chatbot just to make sure that it was working the way it was meant to work. The third objective involved, and which is what we are currently on, was participant recruitment, which we did, where we had informed consents signed and explaining to them what the project would be. We trained the participants and actually even got more questions during the training. Remember, these were a different subset of users than the ones that we got the questions from. And so we are currently having the users use the chatbot, and this is being done in 2 of the high schools, 1 in each county, and the 2 universities. So we are currently in the monitoring phase. We are getting feedback from the users telling us this is some of the problems we are having. We are doing analysis of that as well. And our main aim is to make the chatbot a bit better. This is just a session, 2 different schools that I mentioned as they were being presented to the chatbot. There was a projector because they couldn't carry the phones to school. There was a projector just showing them how the chatbot works, and then now we got them to install it during the holiday. So timeline of our activities. So we are doing the chatbot used now. This was running all the way to end of May. We're actually about to close out the project. So we are hoping we can start off on some journal publications. We can be able to do the final report by the end of July. Now, the biggest thing that I want to say I've learned from all this engagement is you do get surprises, especially when you go out to the community. For instance, one of the surprises that we got during the last stakeholder engagement meeting where they were reviewing the chatbot was we had some experts come in from one of the government agencies for HIV. They're called Maisha Youth and NSDCC. And they were commenting that this would be a good system that would be used by a different subset of people who are not in school. And these ideas, you didn't get them unless you actually have had stakeholder engagement. They even gave us ideas of how to make the language much better for the youth. So stakeholder engagement has a way of bringing in, I want to say, the researchers and trying to bridge the gap between researchers as well as the end user, as well as anybody who is in between, and trying to come up with a cohesive system. So for the researchers, I was not the only one. I'm just the project lead for the Belrhiti project. The 4 researchers plus 1 who is not, who joined us a bit later on, who is not presented on this slide. We belong to what we call the Innovate AI Health Lab, where we are trying to come up with solutions for AI towards health. So I'm the project lead for that health lab as well as for this project. We had Dr. Gaki, who is the machine learning and big data expert. We've got Dr. Rono, who is in applied mathematics. So she came in as an infectious disease modeler. And then we had Dr. David Moko, who was the AI analyst. And the last member who is not presented here was Stanley, who is a counseling psychologist in the team. Thank you. I know I went a bit fast just to make sure that we don't run over time, I guess I'll pass it back to you, Salvia.
Thank you so much, Victoria. That was very insightful. I am going to convey a few questions that have been posted in the Q&A. One of them is about, a few of them actually are about data privacy and consent, so I'll combine them for you. It is, how are you going to handle data privacy and security concerns, especially considering the sensitivity of HIV status information? And then it's also around another question about informed consent and the autonomy and privacy of its users.
All right, so thank you for that. I'll first answer the last question, the informed consent. So before each, so we have two age groups that I want to talk about. We've got the 14 to 19, give or take, and then we've got the 19 to 24, 25. So the teens, before they could even start use of the app, they had to put consent, because they are allowed to put for themselves consent, but then they also had to get consent from their guardians and from their parents. So before we could actually allow them access to the system, we needed permission. For the university students, the second age group, they were just giving their own consent. Now, the second question on privacy and how we ensure that there's privacy of all the users within the app. Number one, this app is a bit, at the moment, because it's at the pilot phase, all this data is only accessible to the researchers. Each user has to log into the chatbot before they can use it. They also have the option to clear their data, just because privacy, as far as it's from the server end, privacy also occurs at the user's phone end. So they have that option to clear their data. And then we've also made sure the engine that was used to develop and where the system is hosted actually is secure. Yeah.
Thank you. And one last question. What role do collaborations with local healthcare providers, government agencies, and community organizations play in the success of this AI tool?
All right. So some of the things that we've tried to do from the very beginning, with the counties we were working with, we made sure apart from the approvals that you get and then you can start research, we made sure we had courtesy calls to the different counties, got people who are in leadership to work with them. We also got in touch with I want to call it, it's our HIV organization as per the government. It's called NSTCC, National Systemic Disease. And by getting them to come into our stakeholder meetings, they were able to give us ideas in how to make the tool much better, ideas how to get it, first of all, tested into other counties and to get it implemented and accepted by the government itself. So the collaboration is mainly introducing yourself, trying to get them to buy into your idea, come for your meetings, and then you're able to actually get ideas of how to make it better for them to embrace it. Yeah.
And one last question, just because we have 1 minute. How are you reaching communities of children who do not have access to devices and technology, and yet awareness is necessary in that group too?
All right. So we haven't yet moved to that. However, we had been toying around with a way in which we can provide a system that works on feature phones. And you will realize in at least every household, there's a feature phone. So we're trying to see, because the problem with our technology, first of all, it already causes a digital divide because only focuses on those who have got smartphones. But then we were trying to see how we can include feature phones for them. Secondly, during our focus group discussions, we developed brochures that we gave out in the schools, brochures on HIV, what HIV/AIDS is, frequently asked questions, and then, of course, trying to explain a bit about the project.
Thank you so much, Victoria. I would request you to look at the Q&A and answer some questions, because I can see some follow-up questions as well as some questions, broader questions around the project. Thank you so much.
Thank you.
We will move to the next case study. And our fourth panelist for today, Enrique Cortes Rello. Enrique is the leader of the Tec de Monterrey Artificial Intelligence Strategic Area. He leads academic research, consulting projects, entrepreneurship, and outreach activities related to all aspects of artificial intelligence nationally. The strategic area studies the application of ethical AI to social and economic challenges, with emphasis on explainable AI, reliable AI, resource-aware AI, the collaboration of humans and intelligent systems, and the measurement of impact and risk in banking, agribusiness, manufacturing, health, education, government, and other areas. Enrique is also a member of several venture funds investment committees specializing in science-based startups. Before Tech, Enrique was managing director of Luxoft. This Swiss firm applied AI and data science to physical and digital products like cars, agricultural machinery, and large e-commerce platforms. Before that, Enrique worked for Perro Systems, acquired by Dell in the UK, Switzerland, India, Malaysia, and the Philippines, helping clients with complex digitalization programs in the manufacturing, financial services, healthcare, and telecommunication industries. Enrique's academic and professional journey is a testament to his expertise. He holds a degree in computer science from Tec de Monterrey and has pursued master's and PhD studies in artificial intelligence from Arizona State University. He has also honed his leadership skills at the prestigious Harvard Business School's Leadership and Services program. We'll now hear from Enrique.
Hello, good morning, good afternoon, good night, everyone. The two previous chats were fascinating. So this will be a little different. We're going to talk about something that already happened, and I'm going to focus on the lessons learned in a very practical way. Just to put this in context, this happened between 2022 and 2023, the end of 2020. Well, beginning of 2024. I should tell you, diabetes is a big problem in Mexico. And there is an illness called diabetic retinopathy that diabetic people develop. And this is a very horrible disease. So what I'm going to describe to you is what we did, what were the results, and I'm going to focus completely on what were the lessons learned. This describes more or less the patient flow. We need to know a little bit about diabetic retinopathy so that we understand why we did what we did. This illness is incurable, doesn't have a cure, but it's treatable. And it's very difficult to diagnose because it doesn't have any symptoms, especially in the early stages. So you can have DR, diabetic retinopathy, for 10 years, don't have any symptoms. The second you have symptoms, you go to the doctor, but the problem is the consequence of untreated diabetic retinopathy is you will be blind. Okay, so it's a very tragic thing. This illness is only diagnosed by a retina specialist. In Mexico, and this is a Mexican true data, there is one retina specialist for every 16,000 people that have diabetic retinopathy. And the other one is the symptoms, right? Is you don't have symptoms, and the specialists, they concentrate especially in cities, big cities. So before our intervention, the worst case where if you're a patient in a level 1 clinic, which in our context means a rural clinic or a small clinic in the city, and you had DR, probably you will never be diagnosed and you will become blind. That's the worst case scenario before our intervention. In the best case, usually these level 1 clinics have a doctor, a general doctor. So it's possible that the person goes, the doctor detects diabetes, the doctor says, why don't you check your, why don't we do a check for diabetic retinopathy, sends the patient to level 2, which is a mid-sized clinic. Doctor in level 2 see the patient and decides to send to level 3. Level 3 is in a big city like Mexico City, and that's where the retina specialist is, diagnoses, treats, no problem. The problem in the best case is there are 9 to 12 months delay between the time the doctor in level 1 and the doctor in level 3 interact, right? The patient loses 12 months. So what did we do? We took an approach of using AI to do a screening for diabetic retinopathy. This is a well-known technique. So let's say the models were not very difficult to develop. We put cameras in rural clinics, and we use telemedicine. I'll explain how. So in the new case, let's say A/B testing, there is a technician in the level 1 clinic, along with the general doctor, takes 2 pictures of each eye with a special camera. We develop a model that screens for diabetic retinopathy. Not only are you ill or not, but what degree. If there is a high probability, then the images, and this is where telemedicine works for us, those images and the rating were sent to a remote retina specialist, not to the specialist in Mexico City, but we made an alliance with a body of specialists that check the AI result pro bono. So they check, they send the check back. The model was, I would say, has a good probability of success, but we wanted a human in the loop. If the retina specialist verifies that there is DR, then the level 1 doctor in the rural clinic refers the patient to the level 3. And then if the DR diagnosis is verified, then the patient is treated. This reduces the cycle from level 1 to level 3 to 1 week. So you are comparing the before and after from 12 months to 1 week. But really the screening, the AI screening of the images takes seconds. So you could say you have a pre-diagnosis in seconds, and then you have a referral to the retina specialist, and you are showing up in the clinic if you are the patient in 1 week. So we did this, we designed an experiment. We screened 1,000 patients with this method, the after method, in 3 clinics in a state of Mexico called Jalisco. Technology was camera, telemedicine, and neural net model that could discern if retina picture had DR or not. Of the 1,000 patients that we saw in the experiment, 60 patients were diagnosed, they were referred, and they were treated. So 60 patients are not blind now. And another 100 were referred, and they had other illnesses, but not diabetic retinopathy, right? So that's the social result of this experiment. And then we did something interesting, which is we measure the return on investment. So in other words, we gather all the cost of putting the camera, develop the AI model, putting the technician in the clinics, developing communications, etc. And then we compare that with the effect, the economic effect of 60 patients not being blind. And this is interesting because for every dollar that the after case cost, society receives between $3 and $10 back in a period of 3 years. In other words, using AI in this context is not only good for social purposes, but is a good business for the government. Now, so this is the case. Let me go to the learnings. And these are real learnings and tough learnings. First one is Dr. Zakaria talked about large coalitions of partners. We had, I'm here representing a very large team, by the way. So we had International Development Bank, we had us, we were called Tec de Monterrey, but we also had involved the Tech School of Medicine, which is a separate entity. Then we have the Academy of Ophthalmologists, which were the ones putting their time pro bono to check the results of the AI screening. Then we had to involve a school of optometry. Then, of course, we had to involve the state government of the place where the clinics were, including the Ministry of Health. Then there is something different, that is the operator of the clinics, which is different from the Ministry of Health. And the reason is the Ministry of Health is a political entity, and the operator is more of a civil servant entity, plus all the people in the H clinic involved. Now here, what we learn is it's incredibly difficult to align the interest of such a giant coalition of partners. And you have to do it, and you have to do it beforehand. You need to align the goals, and you need to align the incentives. And those goals are sometimes explicit, and sometimes are not explicit. They are not spoken. So we had to do a lot of socializing and thinking and trying to see what are the goals of all these parties and align their interest. And what was very powerful is we put the patient at the center of the experiment. So every time we had a discussion that was not going well, we said, what is best for the patients here? So that's one lesson, is to assemble and coordinate a large coalition is difficult, and you need to align their goals. Second thing, ethics and law. Because we're using biometric data and we are intervening in a health system, we created an AI ethics and law review committee in the university. This is not, doesn't report to me, it's completely independent. And this committee flags ethical and legal risks before the system is built and through the design and the cycle of implementation. The only thing that is regulated as far as this experiment in Mexico is the data, especially biometric data. Is regulated by a personal data protection law. The regulator is well known, and so we know what the law is. What is not regulated is the use of machine learning or AI in a medical context. So there we had to be guided by ethics, okay? But this is a very important step. Next one, data. Lots of challenges with obtaining data. Of course, if you are using machine learning, you need data to train, and this data needs to be labeled. Our first approach was to find quality open data. We couldn't find any quality open data about retinopathy and images of eyes in Mexico. Finally, we found some open data that was, we believe, sufficient in the United States. What we found after some examination that this data was biased towards a specific population. And that specific population, just to give you an example, was women that were obese and they already had diabetes. So that was not representative of our population. So we had to generate our own data, which took a long time and it was very costly. So we generate our own data and we tag our own data, and then we partition for training and testing. So data was an unexpected barrier. Infrastructure, the left-hand side pictures are the clinics where we put the experiment. As you can see, you know, they are normal small clinics. And we were told that these clinics had the necessary infrastructure. So we said we need internet, Wi-Fi, we need a certain furniture, we need a dark space to put our cameras. We were told by the authorities that all that infrastructure existed. And when we showed up and we did an inventory, many things did not happen. One of these centers did not have internet at all, although it was listed as having internet. One of these centers didn't even have the proper furniture so that we can put our camera. So I had to borrow some furniture from the university. So we had to provide the infrastructure as part of the project. Esther talk about communications. This is key. Informed consent is necessary. not only from the ethical point of view, but also from the law point of view in Mexico. The type of patients we were screening were underprivileged people, 45 plus years old, and a fifth grade of education, so it's primary education. They could read and write in a basic level. Although they had cell phones, they not necessarily are very sophisticated users of social media, etc. So we need to obtain informed consent, which you may imagine is difficult when you have that pattern of patients. So we had to do a survey so that we get the profile of the patients. And then we spend a lot of effort and time to make this communication clear, simple, and appropriate to a person, men or women, 45-year-old, fifth grade of education, underprivileged. I think we succeeded, and this matches with Esther's observations. We use a combination of posters and infographics, and we use a lot of paper. We didn't use electronic communications. We also trained our technicians to be very patient and very empathic with the patients, because informed consent in Mexico has to be in paper and signed in paper. So you need to keep paper records. So lots of time and effort went into this. It was time well spent. Next one, we needed to understand the government structure, which is not easy in any country, but in Mexico is hellish. We made a bad assumption when we started the project. We assume a top-down hierarchical structure in the government, where you have a state governor, and then you have a minister of health, and then you have the bureaucrats that deal with the health system. And our assumption was completely wrong, because we thought we had gained, let's say, the approval of the highest level in the bureaucracy, but the hospitals, or the level 1 hospitals, were operated by a different entity. So when we showed up and we said, look, we have the governor backing, we have the minister of health backing, they said, well, we don't care because we're a different entity. So that was our mistake. We should have done a better mapping of government structures and their interests and goals, right? We also didn't understand really well budgetary cycles. We did not understand very well electoral cycles. At the end, we came out with a PhD in government structure, but this was costly and time-consuming not to understand it. Next, we believe we understood the health system processes. What we did not understand is that many processes cannot be changed and will not be changed. Even if we believe they were not efficient, that's the way it is, because they are written in law. So, for example, in Mexico, there are many things that require a paper record. The paper record needs to be filed. You can have a backup that is electronic, but the official record is paper with signature in ink, right? So that's the one thing we didn't fully understand, but when we understood it, we kept a lot of paper records. Also, we didn't understand that referrals are only made by a doctor, not by a technician. And once we understood that, we must have a doctor there. And something that really we didn't understand is many doctors in the Mexican health systems, they don't have permanent contracts. They have 10-month contracts. They stop in Christmas time, December, and then they start in February. We didn't understand that, and we were running our experiment through Christmas. So what we had to do is to pay them out of project funds, right? So that we had continuity. Measurement of impact was very important for us because that's something that we study. So we were very careful measuring the social impact, right? How many patients were screened, how many patients were referred, how many patients referred show up at level 3, and how many patients were seen and treated. So that we have all that record, which is good. But what is not very common is to measure the economic impact, the return on investment. You need to use econometric techniques to calculate return on investment. And the reason is the investment is clear because we have records of the project, right? This much in cameras, this much in building the model, deploying the model in software, cloud, et cetera, et cetera. So we knew the cost, not necessarily knew the economic impact. So we did a study, which was, I think, very unique in Mexico, at least. And we understood the economic impact to society and to the health system. And this is really broken into what are the benefits to the families of the people that were not blind because they were treated. So they didn't lose their jobs. People in their family didn't need to take care of them, et cetera, et cetera. And then the impact to the health systems is also important because you get patients that are in the early stages, so they are very easy to treat, against getting patients that are in the late stages of the illness, and they need much more difficult and costly interventions. So we did that measurement. Finally, this is a great lesson. Doctors are awesome. I'm not talking about doctors only, medical personnel were awesome. At the beginning, we got a lot of resistance from medical personnel. Understandable, because they said, look, man, I always work. I already work 12 hours a day. I'm killing myself. Then you come with your little experiment. You're wasting my time, probably. So it took a lot of time, effort to explain to the medical personnel what is AI and why is this good and what will happen. And they had to imagine all that. But once they got that this was good for their patients, they were our best allies, unstoppable, great people. So we were very inspired by their work ethic and by their enthusiasm and by the love these medical doctors have for their patients. So I'm summarizing now. AI is a very small part of a project like this. Most of the lessons were about the political system, the stakeholders, the processes, the change of processes, and the incentives. So somebody told me that, hey, AI is a little piece. Yeah, it's a little piece. Lessons learned at a big level, technology, AI, building telemedicine, relatively easy. We know how to do it. But obtaining the data is difficult, and no data, no AI. Second, patients must be at the center of the design of experiments because that removes many barriers when you talk about, hey, this is good for the patient. We need a very strict and very agile program management, including risk management, change management. And when I say agile, I mean it needs to adapt to conditions that we didn't anticipate. You can do a lot of risk management, but I guarantee you, you will face things that you didn't think about. Finally, don't make any assumptions, verify everything. Even if some people tell you that your assumptions are right, go verify. And must have very deep understanding of government structures, health system processes, and how to manage change within those existing processes, because they will not change because you show up. And I think I'm done. Thank you.
Thank you so much, Enrique. Those were very important lessons you shared with us today. I will convey some of the questions to you now. And one of them is about stakeholder engagement in the future. How do you plan to strengthen these partnerships to enhance the tool's impact and sustainability?
Yes, the next stage here is scale up, right? Because we did it in 3 clinics with 1,000 patients. So we need to scale up. Now, some people have trust in us because we showed that what we were doing was right, and that we even show economic value, right? But we need to be aware of things like, for example, in Mexico, we have a federal and local election within days, right? So the bureaucrats will change. And then we need to re-engage the same entities with different people, right? But now we know the mapping. So we have a lot of data to show them and to re-engage. And the ones that stay there, like the Medical Ophthalmologists Association and all those things, we already have them. So it's a re-engagement of the same structures that we understand better, and now they trust us.
Wonderful. Another question is about representativeness. We are being asked how you ensured representativeness, since you said the model was based on Mexican subjects. We know that there are divides in every society.
Oh, yeah. We chose well, we didn't choose the clinics. We asked the health minister for clinics that were homogeneous. So we said we want 3 rural or we want 3 city, but with similar characteristics. Okay, so we didn't try to open the thing too much because we knew that that was going to add layers of complexity. So we said, give me 3, and what they gave us was 3 city clinics in underprivileged areas, right? And they were very practical. They said, if I give you rural clinics, just the transportation and coming and going, this is going to be very bad for you. So we didn't by design, we didn't try to make it very wide in terms of the diversity of people, right? But that was by design. When we scale up, it's going to be very, very different.
All right, so that will be the next stage.
Yeah.
Thank you so much, Enrique. And that brings us to the end of our speaker sessions. We will now wrap up what was covered today. And we first started to hear from Esther, who shared effective communication strategies with us, especially around understanding the audience, identifying common fields, segmentation, as well as developing key messages. She also shared with us selecting the best communication channels based on the target audiences, importance of empathy in communication, as well as adapting communication based on feedback. We then moved on to case studies from the different regions. Dr. Zakaria gave us an overview of his project on reduction of maternal mortality by improving diagnostics using AI, and he also gave us a good idea of mapping stakeholder engagement strategies and for the different phases of the project. Victoria gave us an overview of the Beshte chatbot project to enhance HIV testing, and she shared with us the different engagement activities that were undertaken as part of the project, the stakeholder forum, consultative forum, the development of the knowledge base, as well as the focus group discussions with the sample end users. And then we moved to Enrique, sharing the case study and best practices from the retinopathy project. He shared with us the patient flow, the approach that led to the increased diagnosis and referrals among patients. And he also shared some very valuable learnings as well as the challenges that were faced with each stage, including stakeholder management, ethics and law, data, informed consent, government structures, and the health system processes, as well as impact measurement. That was a summary of the presentations today. So yes, we have come to the end of the workshop today. Thank you everyone for joining. Thank you to our speakers for a wonderful session. If you wish to receive a certificate of attendance for this workshop, there are 2 criteria. One is completion of the Global Health Network workshop feedback survey, as well as to have attended 80% of this workshop. You can include empowering communities, innovative approaches to AI health research and engagement, and the code 280524 when requested. Your certificate will automatically be emailed to you within 1 month. The QR code is also available here if you wish to be taken directly to that link. I will allow about 30 seconds for anyone to take in this information from the slide, and then we will end the workshop session today. Thank you everyone for joining. It was really wonderful to see the engagement in the chat as well as the Q&A. Apologies if we were not able to answer your questions. We'll consolidate them and we will find a way to reach out to you with your queries and responses. Thank you once again to our speakers. That was a very informative workshop. Thank you also to our interpreters for doing such a wonderful job on maintaining the inclusivity of the workshop.